Hello everyone, welcome and thank you for joining us today. My name is João Pedro Ribeiro. I'm the CEO and one of the co-founders of Implant, and I have the pleasure to kickstart this webinar, the second and last of our Before Careerism series. Today with us we have Dr. Sérgio Gonçalves, a dedicated hip surgeon and a member of the hip team of one of the largest hospitals in Portugal, located in Lisbon, Hospital Lisboa Central. Dr. Sérgio will be talking about how to perform hip procedures from simple to complex ones and how PicMed can help you with those processes up to a point where you can also 3D print those bones. But before starting, I would just wanted to highlight one thing. You have on your right side on the YouTube channel the chat option. So we welcome you and ask you to do your questions, do your comments, because we will be answering those throughout the session. So with no further ado now, I would like to thank you once again, Dr. Sérgio, for accepting the invitation, and over to you.
So hello and thank you to everyone attending this, and we'll try to make it worthwhile for everyone. So I'll just start and try and share my screen. Okay, I think it should be working. Can you please confirm it, João? Yes?
It is.
Okay. So, as João said, in this series, the idea is to talk about preoperative planning. And so they talked yesterday about the knee surgery, and today it's about hip. So as he said, I work with a team at Lisbon with the hip and pelvis unit. And so we are a dedicated team to this type of pathology. So without further ado, I have two cases to share with you today. So one is about a hip arthroplasty, which is one of the most common procedures we all do. And another one is about femoral head and acetabular fracture, which is a bit more specific, but also highlights the importance of planning everything from the simple to the complex. So following up with the hip arthroplasty, everyone has had the experience of having simple arthroplastic procedures that go very well, and you think, well, this almost didn't need any planning, to the most complex that you mid-surgery, or if some problem should arise, you have to have different solutions and you have to have thought about them before you went to the operating room. And so this is one of those cases. So this is not for a very complex discussion, but what we see here is the diagram of forces that goes through a hip joint. And so this is what we'll try to do with a hip arthroplasty. We have to take in consideration the abductor arm, the lever that is pushed upon the hip joint. And so the objective of the arthroplasty surgeon should be to correct the center of rotation of the joint, because this will allow for the patient to have a better walking gait and also for the arthroplasty to last longer. So the case I have to show you is this one. I'll show you an AP radiograph and a full limb radiograph. Here you can see this patient was referred to our unit from another institution. He already had a hip replacement on the right side. You can see that this hip replacement is, at least clinically, is working well, but I don't think that any of us would consider it, at least radiological, a great success. So they had an interpuratory fracture and the acetabular cup is a bit vertical, but we'll not focus too much on it now. On the left side, you can see that the patient has severe dysmorphic hip arthrosis. It's hard to figure the joint line. You can see that there's almost no hint of movement. And on the long films, you can also see that there should be a significant difference in leg length. And this patient had a surgery before. That's why you see this proximal femur so dysmorphic. She had a proximal osteotomy to allow for weight bearing. And so this is a very young patient with a dysplastic hip as a consequence of previous surgery. So in these types of patients, I think everyone agrees that this is fundamental to have preoperative planning. So we start the planning by getting correct measurements. In the case of this software, we have a hip replacement, so we can calibrate the image. This will let you prepare for having accurate measurements. In this case, we know that this is a 28 millimeter head. And so from this point on, we know that every measurement we take in the program will be correctly calibrated. And so the leg length, the implants, everything will be according to what we will find in the patient. So going forwards, now that we have the calibration made, we were trying to assess what is the leg length difference. So we have an automatic tool in PeakMed. You just select limb length discrepancy. The software automatically asks you to mark the points. So you mark them. Here it's a bit complicated because of the dysmorphic nature, but the software automatically estimates the limb length discrepancy of the long films. On the left side, you see that we're going to do the automatic procedure to perform a hip replacement. Like I said, it's a bit hard for the computer, but still you will see that it approximates it very well. And it will give you an idea of the femoral offset and also of the leg length discrepancy. And so you will come to know where is the center of rotation of this hip and how much you should correct it. And this will give you a good idea of what you need to do on your surgery. As you can see, the leg length is a little less than on the long films, which is okay because the margin of error is bigger. But you can see there that the center of rotation is quite low compared to what the patient has now. And so this will be a challenging surgery to perform. So going forward in this complex anatomy, we thought it would be better to have a CT scan. I think everyone agrees. And so in PeakMed, you can import your CT scans and you can have a 3D planning environment. So you can have better tools of defining the anatomy and even if planning the components you want to use for your surgery. So this is from the start. So I have here the CT scan I'm going to import and start planning, as you can see. So we'll plan a hybrid environment where you have the axial cuts or the sagittal cuts, whatever you choose, and the 3D planning side by side. So here you can see, I'll finish the importation of the images. And here you get, on the left side, you get the sagittal or axial images that you imported. And on the right side, you have the morphology and the 3D rendering of the patients. So going forwards, what we can show here is the patient has a very dysplastic hip. There's almost no femoral head, as you can see there. The high riding trochanter and the trochanter has been used for the osteotomy, and so it's quite dysmorphic. Here on the axial cuts, you can see that there's a big dysplasia of the posterior wall and the interior wall. And it's not shown, but the measurements here are about 42 millimeters across. So you'll have to use small implants. Here you can see the level going through the reconstruction. And this is helpful to determine the place where you should put your implants, and so that you have a good correction of the center of rotation and that you don't use implants that are oversized for these patients, which would increase the risks of fracture, for example. So after having this, we'll advance to the 2D planning. Since this case is very complex, the 3D structure is very hard to separate the femur and the acetabular part. So here is what we do for the 2D planning. So we're going to move the femur out of the way. And so you need to draw across the femur because it's very hard for the computer to figure out which is which. So we'll get the femur selected, and this will have you a fragment of the distal femur. As you can see, I can move it, so when it has implants, we can put it into the place that it's supposed to be. And so here we'll select our implants. We've selected a multi-hole cup with very small sizes, and then a modular stem that we're going to apply to the femur to allow for this dysmorphic channel and for sequential reduction of the deformity, so we can adjust the leg length, the offset, and everything independently of the canal. So here you can see the acetabular cup. So we've put it on the same spot that the center of rotation was before in the planning. As you can see, if I take out the femur, there's a big hole up above. So this is one thing that we should have attention for intraoperative, okay, for the reconstruction, because the cup might be without adequate fixation on top. And so if we don't plan it, it's hard to think ahead for these types of things. So we've put an acetabular cup with a size 44, okay, multi-hole type with a press fit, and we think that we might need some support up above, but we'll get into that further. So going from the acetabular side to the femoral side, so on the femoral side, we're going to use a modular stem, like I said, and so here you can see the modular stem. I'm going to put it into the picture. So you'll try to align the femoral canal with the stem, okay? So you'll pull it into the femur. And once it's in place, you can start changing the sizes, the length, and you can see that on the left side. So once it's centered, this is about it. So you can see the cut that we're planning. So you can hold it there, and then you select the stem. So a standard stem with a diameter of about 13, okay? And you see a good press fit in the canal. And I think, so we thought we could achieve this intraoperatively. As you can see, you can pull it a bit down, okay, to see if the press fit will be enough. And once you got it in place, you can lock this implant to the bone fragments, and then this will allow it to do the reduction once you get them both in the same spot. And so, as you can see, you have the implants and you have the center of rotation. Everything is planned. You can hide everything so you don't have all the clutter in front of you. And so you have planned separately for the acetabular part and for the femoral part. Going forwards, sorry. Okay. So going forward with this, you know what implants you have and what is expected intraoperatively of the surgery. So this is the intraoperative X-ray, where you can see that those implants we have planned show that you can have difficult reduction, as you can see here on the left. And after this reduction, you can see on the right that we used the bone that was left to fill the defect on top of the cup. So it is fixed with screws, and the cup is also fixed with screws to the pelvis. So you have two types of fixation, and we have this this type of bootay, which is used to enhance bone stock for further surgery if the patient ever needs it. So this is the final result we can see here. So you see it on the left, the long films of pre-operatively for the patient, and on the right, the post-operative films that show the correction. You can see that we were able to normalize the center of rotation for this patient. The leg length discrepancy is almost gone. So you have 420 millimeters on one side and 26 on the other. And you have an increased offset of the left side. And this is partially due to the osteotomy. So the orientation of the greater trochanter is a bit off, but that is mostly due to the pelvic supporting osteotomy that the patient had done before. So this is a very interesting and complex case that I think showcases well the need for planning and for preoperative planning, because all of these things are very hard to get right intraoperatively if you don't spend enough time looking at the X-rays. So I would pass to João and to the community to see if you have some questions or if someone wants to comment on this case.
Yeah. So I'm checking now. We don't have yet any questions. So people was saying yellow, but no questions for now. But I do have one. So I saw that you have used also the CT scan of the same case in order to make the match between what you see on the 2D and the 3D. So this is very common now, where surgeons are starting to feel the need to do 3D planning in general. And I know that we'll see this with a little bit more detail in a second, but I would like to better understand your point of view in terms of 3D planning and this combination between the typical X-ray that you would do normally in any case, but also to use this in combination with the CT and 3D modeling. So what's your take on this? So why do you think it's useful, and why do you believe we are starting to see much more cases with this now?
So I think the most important thing, and this case is a good showcase of that, is high volume surgeons will most likely have the least benefits of using these technologies, but low volume surgeons will have the added benefit of being able to think and to see things way better. I can go back and just show, I don't think it's very intuitive, even for orthopedic surgeons, like this type of deformity is very complex. You can see here the 3D scan and the 3D reconstruction. And even if you plan, okay, in the 2D, it's very helpful to have this type of perspective to what you're going to find intraoperatively. I think no one would give this up, you know, if they were able to choose. And so I think it's invaluable to have these types of tools. The 3D planning itself will be helpful as well, because you will have to choose implants, and you can have on the future implants that are best fitted to your patients, okay, and not just mass produced. So you'll have an individualized opportunity to have better fit of implants to the patients. But I think in a visualization type of effort, it's invaluable in complex cases to have 3D planning and these types of tools at our disposal.
That makes a lot of sense. So thank you. So I think we can move along because I'm sure that questions will
rise, yes.
come. Yeah.
Okay. So going away from hip arthroplasty, I have another case that I wanted to talk about. It's a femoral head and acetabular fracture, and it's a different type of pathology, as we all know, but it's still a very complicated one, and one that has young patients that need all our attention. And so here it's important to have full control of what is going to happen. So we know that the hip joint is a polyaxial articulation, and that the femoral head is not quite a sphere, but almost. But the main thing we need to know is that any incongruency in this joint as a result either of trauma or like in femoral acetabular impingement type of dysplasia, this will lead to bad outcomes in the future and to early arthritis. And so in fractures particularly, most of these types of injuries end up having surgical indication. And so when you go to do surgery, the best case scenario is you have everything in control and you have studied well your case. So the case I bring is of a young boy, 15-year-old, that had a fall and a femoral head fracture. He was reduced and transferred to our unit. Here you can see on the left side X-ray that he has a posterior dislocation with an intra-articular fragment, it seems, and that after closed reduction, you can see there's an incongruency of the femoral head, which is quite clear. And you get a hint that something might be wrong on the acetabular part, which is also to be expected. So femoral head fractures are very commonly associated with posterior wall fractures, and this seems to be the case. So as we discussed, when something is a bit complex and you have some doubts, you have to do a CT scan. This is the same planning environment in PeakMed, so we can choose whatever slices we want from the CT scan and import them into the software. here you can start the planning. And here I'll do an hybrid trauma case and start it. This is real time, so the software is not very invasive in terms of our time. And here I'll select segmentation of bone fragments. This is important because this will allow the system, I'm sorry, this will allow the system to do an automatic extraction of the bone pieces in the picture. So it'll take out the hip joint, it will take the femoral side, the acetabular side, and you don't have to select it, you don't have to hide it manually, so it will do that in real time. And the segmentation takes a couple of seconds at most. And you will be able after this, as I will show you, to see into the acetabulum and see into the femoral side without anything obstructing your view. This will make it clearer the degree of comminution, for example, and the deviation that the bone fragments have from each other. And this is invaluable, I think, when getting adequate exposure and getting into surgery. As you can see, this is live, so it's just a couple of seconds. It extracts the 3D bone segments. And now you get into the menu of the software. And here you can see you have it on the left side. The yellow lines limitate the bone pieces. And on the right side, you have also the 3D reconstruction. As we'll see in the next case, I've already labeled some of the pieces. You can see there the pelvis and the femur. And so here you can go about taking whatever pieces you want and leaving the other ones behind. So you can see there the pelvic side. Here the fragment is the iliac bone on the other side. I'll just delete it. Here you can see the femoral side. Here the femur on the left side, the sacrum, and then the lumbar vertebra. I can just take them out, and now we have only the region of interest that you want to see, okay? And you can take it and you can move the bone pieces around. You can put it in the middle of your picture. You can separate the femur from the iliac bone. You can do everything you need to be capable of defining the anatomy of the lesion as best as you can before going to surgery. So I'll go ahead and show you here. You can just take the iliac bone and you can see there the femoral side and the bone fragments on the inferior parts of the femoral head. And that is the fragment we're going to try to fix. So going further, I'll show you the planning we do for the acetabular side. So here I will take the soft tissue out, and then after the soft tissue, I will delete the femur. This will make it so that you can see inside the acetabular cavity, and there you can see the fragment of the posterior wall that didn't seem very large, but in fact it's a very big piece with a very about a centimeter deviation from the bed. And so this is a lesion that warrants surgical treatment because this hip might render painful, and this will be needed for having an anatomical reduction. You can see it here from above. And so this fragment will need to be fixed and put back into place so that the hip joint remains congruent and the patient can have a good outcome in terms of pain and returning to sports and activities that a 15-year-old will do. So after the acetabular side, we'll go ahead and see the femoral side. It's the same principle. You can take out the soft tissue and the iliac bone in this case, and you can turn the femoral head around. You can see on the cuts on the left side, this is the small fragment that it looks a bit small. You wouldn't care too much for it. But if you see it on the 3D reconstruction, you could see it's a fair big piece. It's inferior to the ligamentaris. And so this is also a fragment that will need fixation and that will need stabilization so that the patient can start moving around fairly soon and with a congruent hip. So we've seen the acetabular side, we've seen the femoral side, and now you think, well, I have planned everything and this is just perfect. But there's some other uses you can have for this type of planning software. And one of those is to have it export this that we have here, so this volume, as an STL file. And that just basically means that you can get a volume outcome of this type of thing. So PeakMed automatically exports this piece. You can see it here on the left side. So this is just the fracture you have. And once you have this exported out of PeakMed, you can just import it into the 3D printing software. That's what I'm showing here. It's a different company, but it's no problem. We'll just import it in. This is the printing machine software. And so here you can see that you can get reconstruction of the anatomy, and you can take it with you. You can use it to show to your residents what you're going to do in the surgery. You can even do the surgery on these types of models ahead of time. And you can instruct patients to as to what they have and do patient education with these types of things. Showing you on the right side, you have several possibilities with the printers. So you can print it faster, slower, more resistant with different materials. So you can do everything that ranges from just showing the model to planning and going about doing cut guides and screw guides. So you can get screws into difficult places. And so I use it mainly for intraoperative guidance at this point. And so we'll slice this. And so in 6 hours, almost 7 hours, we'll have this 3D printed. So it's not a very complicated process. You can see with PeakMed, it's really easy. Here you have the path that the traveling of the 3D printing. And so this allows you to, in a relatively short time, to export a 3D piece of the fracture or whatever you're doing and print it and take it into surgery. And so that's very valuable to us. Here you can see just a brief time lapse of how this happened. So this is called fused deposition modeling. So basically this blue head just melts a bit of plastic that goes into the printer, and it forms the fracture or whatever you're trying to print. And so you can then just take it and show it to the patient or to the residents. Here we have the piece that I was talking about. So this is the fracture. Okay, you see the femoral head, and here you see from behind, you can see there the posterior wall fracture, that it's a big fragment. So now no one has doubts that it's a large fragment and that it needs fixation. And so in this sequence of events, you have 2D, 3D planning, and even 3D exporting for 3D printing. So you can take it into the surgery and it will help you during the surgery. So in this patient, we decided to do a surgical hip dislocation to treat this problem. That's what I'm going to show you in brief steps. So most of you will be familiar with this surgery. So we go through a trochanteric flip osteotomy, so we don't endanger the vascularization of the femoral head. Here you can see the fracture that looked very small on the X-ray, bigger on the 3D planning, and it looks gigantic here on the video. So we put some headless screws in to fixate this fragment. And here you can see the acetabular part, so the posterior wall. We're putting an omen on the posterior wall side. You can see it there, the femoral head. And we used suture anchors on the bed. You can see it there with wires going around the labral joint, the labral fragment. So you can fix it all back in place and then close the capsule, and the surgery is done. So this is the final result of the surgery. You can see we have almost perfect restoration of anatomy for the patient. A very small fragment ended up taking 4 screws. So the importance of it grew as we looked closer. So the X-ray didn't look that bad. The CT looked worse. And once you get it into your hands with a 3D printed part, it looks very, very big. And so this is the final results, and the patient is very happy. She's walking, absolutely no complaints. And so I think in this type of case as well, planning ahead is just without this, it wouldn't be possible to have decent results for the patients. Thank you.
Thank you, Dr. Sérgio. So we have some questions here on the YouTube chat. So I'll read some of them. So Dr. Anderson Freitas is asking if in any situation do you feel the need or do you think it's useful to use an MRI in this type of cases?
Yes. So the MRI usually on these types of fracture will help to define better the patterns of lesions that you don't expect. In this type of case, where you have a bony lesion, it's not that hard to imagine what happened to the rest, but MRI will for sure show if you have capsular instability, if you need to do a capsular repair, for example, or if you have a labral rupture. And so at our center, we always do a CT scan after any dislocation. We do a CT scan to assess the congruent reduction, okay? And if the reduction is congruent, you test the joint. So if there's no instability, we usually don't use an MRI, but for sure, I understand the use you can have for it. But in the acute setting, it's not easy to integrate an MRI into the workflow. And so we don't use it as a first line of diagnosis. Mostly we use the CT, but for sure you can have useful information from it.
Thank you. No, absolutely. And it's also possible to use MRIs with the PicMed system in case you need those. So another question, and I think it's more directed to us, asking about if the automatic segmentation is already available in the system. So the question is yes. So on the list of planes that you would like to use when you are using a CT scan, the axial, the coronal, and the sagittal plane, you have the option to check what it says, automatically segment bone pieces. If I'm not mistaken, that's the text there. We have another question, a very interesting one. So Dr. Anderson Freitas is asking if you have experience with the hip conservative type of procedures, like for example, the periacetabular osteotomy. So do you want to elaborate a little bit on this?
Yes. So I think the idea is if this technology could be useful for periacetabular osteotomies, and I think obviously it can. So we have the possibility not only to do the cuts that you want to do in the planning, and you can also make up the guides to do to guide you. So you can do those with a larger margin of security, and you can miss less. So I personally don't have a lot of experience, but it's like I said in the beginning, I think these types of tools are more helpful to those who have less experience because you have bigger safety margins. And so I know there's 3D planning and 3D reconstruction that is used for PAO, so periacetabular osteotomies, but we mainly do trauma, so we use this in trauma cases most of the time, the acetabular fractures, femoral head fractures, and not that much in conservative type surgery.
Okay, good. So I do have a question now. So we discussed here not only on how to plan or how to prepare for surgery using X-rays, using CTs, and now also with 3D printed bone models. So 3D printing is really one of the technologies that a lot of people within the space, a lot of stakeholders, surgeons included, of course, think that this is something useful not only to simulate the procedure prior stepping into the operating room, but also to use as simulation tools for teaching purposes. So what do you think? Do you think that this would be one of the technologies that will stick, or do you think that is something that it's a nice to have, but in the future will fade away eventually?
Well, I think this is the same with every technology. So you get a big uptake up front because there's very large enthusiasm. Everyone wants to get in on it. Everyone wants a 3D printer. 3D printing is going to solve all the problems in the world. And then you get through the cycle that the more people know it, it's not that linear. So you have to take a lot of time preparing your models. So the engineering that goes behind it, it's very intensive in terms of hours spent in the computer. So I don't think this will be broadly used, for unless educational purposes. For example, you can have bone models that you can download from the internet and you can just use them to teach your residents, to teach your patients. So I think it diversifies the possibilities that you have. But for intraoperative use, it's very resource intensive still. So I don't see that it's going to have a very big uptake in like 1 year or 2 years. But I think it's a technology that will find its place, as everything does. The same as virtual environments. I think all of those things will come and help us, but I don't think this will be the fix for all the problems that hip surgeons have, of course.
Okay, thank you. So we have more questions now in the chat. So Dr. Levi Fernandes, so I will read which is best. So great presentation, Dr. Sérgio. In the first case, you show on the contralateral side that there was a bad position of the cup and the circlage for the femur fracture. So assuming that it was a simple THA, would you consider that even for simple cases, there is always a place for preoperative planning? And do you plan every THA, or would you consider that after starting using PICMED? And then it says that he understood that the surgery was done in another center.
Well, we do it for every patient we have. So we have no simple cases. That's one of the things that our colleagues accuse us of. So there's no simple cases, because every time you use it, you build proficiency doing it. Because if you don't do it on a regular basis and you want to do it on your difficult cases, then you don't know how to do it. Then you take too much time. So it's good to build up the experience. And we use it as well because it allows you to have a better workflow in the hospital. So if we do it preoperatively, the nurses will know which implant sizes you want, so they'll get less times the implant wrong, so they will not have to go out of the room twice or 3 times to get a different implant. That will lower the rates of infection. So I think there's a lot of things that are positive. So we make an effort to plan everything we do. Trauma cases, hip replacements, revisions, we use it on a daily basis, and we are trying to implement it so that everyone around us also uses it, because we think it lowers the complication rates.
Yeah, it makes a lot of sense, and that's in fact why we are all here having this kind of discussions. So we are all prepared before stepping into the operating room. So we have another question from Igor Silva. So does the software incorporates or gives the surgeon information about patient-specific pelvic tilt when planning for a THA, and the same for spine-pelvic relationship?
So the software doesn't have that built in at the moment that I know of. And this is a very hot topic in hip replacement world and literature. What we do in our center is, when we have patients that have stiff spines, okay, so if we have patients that have been instrumented, lumbar fused, or if they have any pathology that takes out spine motion, we'll get them to do sitting x-rays, so lateral sitting x-rays, and then standing x-rays, and we'll measure the tilt difference so we can adjust intraoperatively. But I don't think the software has that built in at the moment, and I don't think that there's a large consensus in the literature that even if you have this information, how can you go about doing it? So I think this needs a further improvement, that is intraoperative guidance of surgery, either robotic or with with digital systems. But in order to make that information useful, I think we need to get further ahead into intraoperative systems that aid the surgeon, being robotic arm surgery or navigation. And I think that is the next step, is that you can plan, and then you also have those aids intraoperatively, so you can execute it, the things you planned before.
Yeah, and I can confirm that. So in fact, and to add on top of that answer, which I fully agree, inside of the spine module, we do have the option within the sagittal balance to calculate pelvic tilt. Although, again, and I fully follow what Dr. Sérgio was saying, that there are no consensus, or there is no consensus around this. So it's one of those topics that is kind of interesting to discuss, maybe for another time. But if you want, you may try that on the spine module. But again, there is no consensus around it, so we are happy in any case to help. So I think that was the last question, at least on the chat. So I'll do the last question before we wrap it up. So we discussed here again 3D planning, 2D planning, 3D printing, guided surgery, maybe in the future robotics, which is a reality today. But what do you think will be kind of the next high tech particularly for hip surgery? So what do you think, or what do you expect to see in the near future to be one of those high-end technologies?
Well, I think the big leap forward will be, so one of the things that technology can do is get the outliers out. So the extremes, we want everyone to be in the middle. So we want every surgeon to be able to do a good hip replacement that serves their patients for many years to come. And so I think technology helps in getting rid of the outliers. So the very bad people and the very good people, they tend to be normalized. So I think guided surgery, I think, will be the future. I know it's a bit heavy on investment right now, so you have to have a big upfront investment, and that is difficult to sell to the stakeholders, to hospitals, to health systems and everything. But I think you start to get big data. I think the real revolution is big data. You can see that on registries, for example. Registry data allows for conscious choices to be made. And I think that will be one of the driving factors of surgeon assistance, will be the fact that in registries, patients that have surgeries, either robotic or guided, will have better outcomes, so their hip replacements will last longer. So that will give the feedback that we need to sell this to our companies, to our hospitals. And so once you get that loop closed, I think that surgeon guidance intraoperatively will be very important. But I think there's work to be done to justify those investments still. And I think to have that investment justified, you have to have registry information and long studies showing that the outcomes are clearly better.
True. And I think that one of the technologies that at least we believe will help with that is, of course, machine learning and deep learning technologies, where you can train and learn with past experience, so you can boost and improve what will come next. So, Dr. Sérgio, I would like to thank you once again for the invitation. I think it was a great talk. So for the people who is seeing us now, I would like to thank you once again for being with us today. Just or go and check our website and blog, because we will have in the near future, next year, more webinars like this, where we'll discuss new technologies and how PeakMed can help you with different types of procedures. So please check those in the future. So once again, thank you.
Happy holidays for attending. Yes.
Yeah. Happy holidays and stay safe. See you next year. Thank you, Dr. Sérgio.
Thank you.